Hi, everyone. Good afternoon. Thank you so much for being with us today. Before we start, I'm going to review some logistics. This talk is being recorded. We are offering this talk in Spanish. Speakers, we ask that you speak slowly and one at a time to capture the translation. I'm now going to ask our student assistant, Flor, to please announce and add instructions to the chat for the Spanish call line.
Hola, buenos días. Mi nombre es Flor. Si necesita asistencia en español, contamos con una llamada en vivo donde traducimos toda la información de esta videollamada. Por favor, llame al número 605-313-4434 e ingrese el código 829406. También puse las instrucciones en el chat. Gracias.
Thank you so much, Flor. Please mute yourself if you are not speaking. We are taking questions throughout the session and will answer some of them at the end of the panel. Please utilize the chat on Zoom for questions or ask the Spanish moderator. This talk will be posted on our YouTube channel and Twitter account at UCLA Pritzker within the next week. A note on geography. We are based at UCLA in Los Angeles, California. Consequently, the majority of our work revolves around the LA County child welfare system. Understanding folks are joining us from across the US, we will do our best to share information that is relevant to all jurisdictions. With that in mind, we invite you to introduce yourselves in the chat. Feel free to share your organization, your role, and why you are joining this session. Now for introductions. On behalf of the UCLA Pritzker Center, welcome. My name is Taylor Dudley. You will see our production team, Ruby, Flor, Nicole, and Brittany assisting throughout the event. Please feel free to write to them in the chat if you have any questions or needs. Welcome to the UCLA Pritzker Center's Winter Speaker Series on Domestic Violence and Child Welfare. This work is funded by the Anthony and Jeannie Pritzker Family Foundation, the Van Nuys Charities, and the Blue Shield Foundation of California. We are pleased to co-host this event today in partnership with the LA County Domestic Violence Council. Countless children enter foster care due to allegations of domestic violence in the home. Often these allegations result in a finding of neglect for failure to protect. Yet removing children from their homes and placing them in foster care for an isolated allegation of domestic violence can result in further trauma for both the survivor and the children and result in other harms, particularly in diverse communities of color. Our work examines this dilemma and the import of child safety coupled with the challenges of family separation. With support from the foregoing foundations, we have been engaged in research over the last year to explore the gaps in policy, practice, training, data collection, and cultural competency where domestic violence and foster care merge. This series highlights 4 areas where that intersection is particularly relevant. This is our first session in a series of 4. This session will explore how domestic violence comes up in medical settings and how providers can respond with the whole family in mind. ACEs and some of the medical and mental health consequences of domestic violence will be explored. Today, we are pleased to begin this with a brief presentation to set the tone from our medical students, Mariam Khan and Taylor Thaxton. One moment, please, while I share my screen. Please go ahead, Taylor and Mariam.
All right, hi everyone, my name is Taylor Thaxton. I'm a second-year medical student in the Drew UCLA program.
Hi everyone, my name is Mariam Khan, and I'm also a second-year medical student at UCLA.
So this past summer, we were really lucky that we were able to join the Pritzker Center in their work in understanding the interaction between domestic violence and the child welfare system in Los Angeles County. So we joined a team of students from across UCLA, from the law school, public health, even undergrad, and we were really happy to be able to contribute the medical perspective on this issue. So just a little bit of background, as Taylor mentioned, the report that we were working on focuses on how child removal in cases of intimate partner violence or domestic violence can be harmful or productive. and to assess whether there are evidence-based trauma-informed services that could be used in place of foster care. Just a little bit of background. In California, the failure to protect law is frequently used as the basis for child separation when intimate partner violence is taking place in the home. So Mariam and I wanted to look at adverse childhood experiences and see what in the medical literature explained whether or not family separation was a benefit or a harmful intervention, and what we could be doing more broadly to improve outcomes for patients who are dealing with domestic violence. So we wanted to look not just at the survivor, but also the larger impact that the family would have to deal with. So we conducted a literature review over the summer, and Mariam's going to talk a little bit about the findings pertaining to the children in these families, and I'll focus a little bit more on the system-based interventions we were looking into.
Thanks, Taylor. While we found no studies evaluating the child's health impacts of foster care versus family care in intimate partner violence or IPV cases, we were able to look into the child's health impacts of intimate partner violence and foster care placement separately. Witnessing IPV in early life has been established in the medical literature as an adverse childhood experience linked to chronic activation of the stress response. The hypothalamic pituitary adrenal axis, or HPA axis for short, represents our chronic stress response in the body. In the short term, our stress response is adaptive, but chronic activation of the HPA axis leads to dysfunction across multiple physiologic levels, such as chronic basal inflammation, impaired cellular immunity, abnormal glucose metabolism, and altered brain structure and function. The prolonged activation of the stress response following any toxic stress exposure perturbs our body's immune and metabolic systems, so much so, resulting in significant morbidity and mortality risk over the life course. Ultimately, IPV can disrupt a caregiver's ability to provide optimal caregiving because they themselves may have difficulty regulating their emotions due to being victims of violence, or are affected by IPV-related psychopathology, such as depression, anxiety. Consequently, the caregiver is unable to buffer the child from harmful effects of a chronically activated stress response. While foster care is considered a protective intervention in child maltreatment cases, there is limited evidence to support such a drastic intervention for children exposed to IPV alone, especially when there is co-occurring childhood trauma associated with family separation and unstable foster care placement as well. For example, children with unstable foster care placements, meaning they end up being placed with multiple different foster families, have blunted cortisol production patterns indicating dysregulation of that HPA axis I mentioned. Cortisol is a chronic stress hormone. And so this all makes sense because if a child is unable to have a secure, nurturing, consistent relationship with their caregiver, they will suffer the harmful effects of a chronically activated stress response. A secure, ongoing relationship between caregiver and child is essential for healthy development. While it has been challenging to disentangle the individual effects of foster care placement from the effects of child maltreatment, we found that children in foster care were more likely to develop a reactive attachment disorder than maltreated children who remained with their birth family. A reactive attachment disorder is a condition where one is unable to establish lasting healthy bonds with caregivers, and it can lead to further complications such as antisocial behavior, addiction, depression, anxiety, and more. Additionally, we also have to note that while foster care placement is found to be protective physiologically in the cases of child maltreatment, emotional, physical, and sexual abuse continues once children enter the child welfare system, suggesting that foster care may not be protecting children from incurring additional toxic stress. Ultimately, research shows that adverse childhood experiences that disrupt attachment relationships between children and their caregivers, especially the forced separation from a caregiver, are a significant predictor of risk for child's emotional or behavioral problems. And research shows that parental child separation in early childhood is associated with shortened telomeres, a biomarker of molecular aging that may explain the poor mental and physical health outcomes we see in this population later on in life. Now, there's so much more to unpack here, but I'm going to let Taylor delve into the research on domestic violence screenings in clinical settings.
Thank you, Mariam. Okay, so the clinic is a really unique space where challenging conversations regularly occur. And it also is unique in that it offers survivors privacy that they might not be able to have in their day-to-day to hold these difficult conversations in the absence of their abuser. And while these aspects are positives that would indicate that providers are particularly situated to intervene in cases of domestic violence, although the ACA covers the full cost of routine IPV screening intervention for female patients, it's not something that's regularly occurring, either screening or competent interventions. So we know that 1 in 4 women experience intimate partner violence over the course of their lifetime, but that's not reflected in our medical documentation, especially in the emergency department, where survivors frequently seek help, but aren't often asked whether or not they're experiencing significant traumas based off of their intimate partner. And what I found really interesting is that patients want providers to ask these questions. They think that it's important that their doctors know what they're dealing with, and providers know that domestic violence is a significant public health issue and want to be involved in helping their patients. But because our medical education and our healthcare systems are not supportive or a lot the needed resources to intervene in these cases, providers don't feel comfortable or confident in their ability to engage regularly with patients dealing with difficult issues like these. So something that I found really interesting was that providers who were able to receive increased training perceived less barriers when it came to screening for domestic violence. And it was also really eye-opening to understand that it's not enough for just, providers who want to do the right thing, who want to be involved and help survivors who are dealing with intimate partner violence, that it also needs to involve institutional support and allow for the development of strong community relationships and to develop ties with community resources that will allow providers to intervene without necessarily requiring the involvement of the child welfare system. So it's good on one hand to encourage people to screen, to ask difficult questions, to engage in these conversations. But if at the end of the conversation, you don't feel confident in the resources that you're able to offer, it makes it so much more difficult to even take that first step of asking people to delve into these really difficult topics. So if our end goal is that we want patients to know that domestic violence is a health issue, that their provider is someone that they can turn to for support when they're dealing with these issues, then it's going to take a lot of work, a lot of really strong messaging to get the point across that it's not just the survivor who is going to be impacted, but the children in their home as well, who also need to be cared for and offered really strong resources if we want to avoid the difficult outcomes that are involved with ACEs. And it also really suggests the importance of continued provider training and a lot of resources that allow them to confidently intervene and engage with these patients. So Miriam, do you want to touch on our future steps, directions?
Yeah, thanks, Taylor. I hope you all can appreciate that there's so much complexity here. And that's why Taylor and I are continuing our research with the Pritzker Center As Taylor Dudley had mentioned, we're in the process of writing a report that was commissioned by several key stakeholders. And so we're going to be continuing that, and hopefully we'll be having a summit in the future where we can present our findings to the public. I just want to highlight that it's been such a pleasure working under the mentorship of Taylor Dudley and Dr. Langley in collaboration with several students from multiple disciplines. And we hope to continue doing our part in promoting the well-being of children and families.
Thank you so much, Mariam, and thank you so much to Taylor for sharing their work with us. We greatly appreciate your contributions. And for now, we are going to turn to our panel discussion. As a reminder, we are taking questions in the chat, which we will compile and attempt to address as many questions as possible at the end of our panel. For those of you who were asking, we also put the link to the poster presentation in the chat, so you'll find it there, and Brittany can add it again if needed. So our panel will be moderated by Eve Sheedy. Eve is an attorney and the LA County Domestic Violence Council Executive Director. She is a dear friend of the UCLA Pritzker Center, and my assumption is that she's also a dear friend of many of you as well who are joining us today, because she's such an incredible partnership. We are grateful to Eve for her moderation, and we will now turn it over to her to begin our panel. Thank you, Eve.
Thank you so much, Taylor. And we're really, the DV Council is honored to be working with the UCLA Pritzker Center and the rest of the team on this really important project. So very, very briefly, because I did see a lot of names of people who are not involved in the DV Council. So let me very briefly explain about that and urge you to join us. So the Domestic Violence Council was moved into the Department of Public Health in the end of 2017. I've been there since the middle of 2018, and that's a recognition by the county to really address violence, to sort of underscore what was said previously, to underscore how important it is to look at this issue as a public health issue, and also to really improve. I think part of the poster presentation underscores how important it is for us to change the dialogue that we have around violence, and particularly that we have around intimate partner violence, because our ability to speak and be open and address this issue, which impacts so many people throughout our community, will help us to change our universe in a better way. So the Domestic Violence Council is two things. It is the county's Domestic Violence Coalition, which is made up of survivors and providers and interested parties, government agencies, and you are all, every single person on this call, invited to join us. I put a website, an email address in the chat where you can reach us, and we do a daily email you can subscribe to. We have a website which has all of our meetings. We have a number of really important committees, including a Domestic Violence Child Welfare Committee, which is ongoing. Additionally, we're a very, very small office, smaller now because of COVID, within the Health Promotion Bureau of the Department of Public Health. And we are charged with both raising the profile and improving the county's response to intimate partner violence, both internally and externally. So enough about me. We have a wonderful, wonderful panel here, and I want to get to them. So we're going to ask them to briefly introduce themselves. So I will start with Dr. Tyne.
Good afternoon, everyone. I'm Shannon Tyne. I'm a pediatrician, and I work at All of You UCLA Medical Center. I'm also the director of pediatrics for the LA County Department of Health Services. And in terms of the subject of this talk, I've spent my 25-year career working specifically focused on children's health and the safety net, and particularly with DCFS, or child welfare involved children and youth. We also have been working on some of the topics raised by our medical students, which is providing better mechanisms for assessing patients and their families for prior trauma, adverse childhood experiences, which include exposure to violence. And I'm really delighted to be here today. Thank you.
Thank you so much. And now I'll go to Dr. Susie Baldwin, who I am happy to say is a colleague of mine in DPH. Susie.
Thank you, Eve. Hi, everybody. I'm Susie Baldwin. I'm the medical director of the Office of Women's Health at the LA County Department of Public Health. I'm a preventive medicine public health physician that actually is a specialty. My clinical work, which was more of the focus early in my career, was centered around sexual and reproductive health, family planning, cervical cancer prevention, and also caring for survivors of violence. Particularly, I ran a clinic for survivors of human trafficking, which is my entree into the issue of violence and gender-based violence. And in our Office of Women's Health in the Department of Public Health, we work closely with the DV Council. We collaborate a lot, as well as with our new County Office of Violence Prevention. We were all just recently housed together in the same suite, not too long before COVID hit. So we actually worked together physically as well as on the topic areas. And Office of Women's Health is our responsibility with domestic violence is twofold. One, we have a unit that actually administers contracts to DV agencies in LA County. And then my unit is more tasked with training and education and working specifically with healthcare providers, starting internally with public health and now expanding into DHS and really helping to improve the healthcare response to domestic violence. Thank you.
Thank you, Susie. And Shanika Davis, you want to introduce yourself?
Good afternoon. My name is Shanika Davis. I am a family nurse practitioner. Currently, I work at Olive Medical Center Hub unit, which is our unit that works with our foster children and families that are involved with DCFS. Over the last, I want to say 20 plus years, I worked with Los Angeles County, originally starting with the Department of Public Health under maternal and child and adolescent programs. I had the privilege of working with Nurse Family Partnership as a home visitor for at least 8 to 9 years, working with our first time high-risk mothers and a lot of the families that I work with had incidents of IPV, and so I received some training in that area. In addition to that, moving and transitioning over to DHS, I had the privilege of working with foster and patient providing primary care services. In addition to, I'm a forensic provider. So with that said, I got a chance to see how from a home visitor, in addition to being a supervisor in public health, and now in person working with our foster, all the programs, how, merging together with the services that I provide as a provider, dealing with our foster youth. Going back to public health, there were many cases that for high risk that we did manage that were in foster care. So I, now being in the hub, I get to see firsthand managing and working with those families and trying to provide services to families that are in IPV and the children, and seeing the effects that it is having on them. I can just tell you a lot of the referrals that actually come in for in-home of parent, for domestic violence. A lot of them are repeated incidents, and it is true in that you do see the effects on the children and the families as a whole, as with the mothers. And sometimes I've seen them in addition to the fathers, and how it has affected family dynamic. I am thrilled to be here, and I love how we're taking a closer look at how other ways we can intervene, because it is true that you see the effects of the removal of the children, how it does affect them.
Thank you very much. Thank you very much. So you actually sort of opened the door to the first question. So I'm going to pose a question and then reverse the order. So and I do want to say this, Miriam and Taylor, you've already been introduced. I'm not trying to cut you out, but you are certainly invited and more than welcome if you would like to respond to any of the questions. I don't know, let us know somehow, wave but so Shanika, I'm going to hand it back to you actually with the question of, he started to talk about, and we're trying to find out how do you see domestic violence, intimate partner violence come up in the medical environment that you work in?
So in the hub setting, we're in a unique situation. I do also have the privilege of working with our referral system, that referrals are that come through to our hub to provide medical care and assessment in our clinics. So from referrals that are transpired through DCFS, in the history, it will tell us a lot of times if this is a domestic violence case. In addition to that, during our assessments, we have staying healthy forms that we use for our families that come in to the clinic. And there are questions for the adolescent as well as the caregivers. If we have the opportunity for our parents to actually come in, so that when we get those forms back, it also identifies if there is domestic violence occurring in the home. And also when we have our when I have my forensic interview with the families, with the caregivers, and those questions are asked, it will come up from that questionnaire. And in addition to, I have the privilege of interviewing the children and finding out the family dynamics. It also will come up during those conversations that I have and the providers have with the families and the children.
Thank you. Susie, you want to address that question? How does DV come up in the medical environment?
Sure. Thank you, Eve. So DV is a really significant issue in the clinical environment. And speaking as someone from the adult medicine side, I've cared for adolescents as well in the context of sexual reproductive health, but I'm not a pediatrician, as the other two specialize here. Intimate partner violence has profound effects on health, not only in the instance of the first thing we might think of, which is in the case of acute injury secondary to assault, but also just in the creation of chronic symptoms and medical problems, things that are associated with many forms of trauma, things like headaches and feeling sick to your stomach and certain body pains, as well as the mental health effects of depression, anxiety, all the way up through PTSD, sleep disorders. So the effects on the body and the mind of experiencing intimate partner violence are profound. And studies have shown that people who experience this do visit the doctor more often, and they have long-term health consequences, including things like stroke and heart disease and asthma exacerbations, things that aren't readily, directly linked to what you think might have happened to them as far as physical harm. But we know that the body and the brain interact in many complex ways through our neurologic system, our hormone system, our immune system. So our bodies manifest a lot of signs and symptoms that reflect the harms we've been through in our lives. And although most of the research in these areas has been done on women, I also want to clarify in the context of this talk, especially since I'm from the Office of Women's Health, we know this is not just a women's issue. IPV and domestic violence affect people across the gender spectrum. It impacts men, it impacts people who are non-binary, who are transgender. And in fact, emerging data show that transgender people have very high rates of experiencing intimate partner violence and domestic violence, as do lesbian, bisexual, gay, and other queer people. So sexual orientation and gender identity don't limit the presentation of harms of domestic violence in the healthcare space. I really appreciated Taylor Thaxton's discussion of screening in the healthcare setting. This is a big topic in and of itself, and I'll touch on it more after the next question, but this is an issue that it's in the clinic every day, it's in the hospital every day, and the barriers that Taylor talked about with provider discomfort about opening this Pandora's box to patient is real. Providers of healthcare are extremely pressured in our current environment, and it's been like this for at least a decade, and it's not getting any better. So people are very limited in time, and our systems are so bare bones, especially in the public sector, that making those essential referrals and knowing who our community partners are isn't necessarily prioritized in healthcare systems. So we definitely need a revamping of a holistic approach to patients so that it goes beyond screening questions to education and connection with resources. And I'll talk more about that after, but I want to make sure Dr. Tyne has a chance to answer this question too. Thank you.
Thank you very much. And Dr. Tyne, do you see the kind of things, in addition to how you see domestic violence come up, do you see the same kind of things that Susie talked about in the adult population? Do you see that in children as well?
Well, I think there's a couple of things to say about, just to dovetail on Shanika and Susie. One of the things that happens in a pediatric visit is that there always is an adult there. And oftentimes the visit is the first opportunity that a parent is alone without the other potentially offending parent. And so you have a really rich opportunity to get information by developing a strong therapeutic relationship with the caregiver. And again, I want to be mindful that it is not always the mother, but to be clear that in the situation of pediatric visits, we know that over 80% of pediatric visits are attended by a female caregiver. So anyway, in that setting, it gives us opportunities to see what's going on medically with a child. And as Susie said, things like asthma that just can't get under control leads us always to think about why that might be happening. Is it lack of access to medications? Is it some stress going on for that child, or some stress in the home that's leading to the child having those issues? And the way that I tend to approach this is from the same model that we've been using for the ACEs Aware rollout across the state. And whether you agree with ACEs or not, ACEs is Adverse Childhood Experiences Screening. The way that ACEs are addressed, or the way that screening should be addressed, is through a modality that includes screening, treatment, and healing, which is the approach that the ACEs Aware takes. And so whether it's related to IPV or any other concern in a child or their family's household, I feel very strongly that we need to be very diligent in our screening and include treatment and healing with it. And the analogy that I always use that seems to resonate with people is, if you do a mammogram and you don't have a surgeon to refer to, don't bother doing the mammogram. And it's not because you don't want to know that someone might have breast cancer, it's because you need to ask a question that you can address. And I've already seen in the chat some questions about being able to access good trauma-informed care services, and that is absolutely critical. So back to the setting of children. So when you see evidence that there are some physical or mental health challenges for a kid, and being able to have that opportunity in a safe space to explore the potential for intimate partner violence, it's such a privilege for a pediatric provider to be able to have that opportunity and develop the relationships that will lead to the disclosures that can help then lead to the treatment. And I know Shanika can talk about this more, but one of the things that we've tried to do, particularly in our foster care clinics, is every child who has an intake has a mental health assessment. And one of the things that we're really trying to build is a relationship with our partners in mental health, and in my case, the LA County Department of Mental Health, to make sure that both a child or children and their caregivers have access to support services they need to address IPV or other trauma that's affecting their health.
Thank you so much. And I do want to add that the DV Council is also presently working with DMH, Department of Mental Health, as well, to try to strengthen that connection from the perspective of the DV Council also. So that was real. Yes. Oh,
actually, I just want to comment back on what Shannon said. I've never heard it phrased that way about the mammography analogy, but it's so true. And it's one of the first things that happens in medicine or in healthcare in general is that we're told to do these questions. You know, the list of screening questions for healthcare providers gets very long. And when these questions are asked in a checklist form, they're not that effective with the patient. The patient knows if you're reading a list and not actually asking them about their life and what's going on with them. And then having the follow-up steps in place and the community resources available is so fundamentally essential. And until that system is built where we know that the screening is going to lead to a positive outcome, there really isn't a good point. You can actually wind up harming people if you have them open up to you and then you don't take action and leave them back in the situation they're in, and they may never wind up talking about it again. I just wanted to add that.
thank you very much. Taylor or Miriam, do you have anything to add? Okay.
I'd just like to add, if that's okay, Eve. In my experience with the hub right now, we do have a multidisciplinary approach, as Shannon spoke about, which is great. Every child is provided a mental health screening, and we take it a step further, making sure that the caregiver, whether it's mom or dad, also has additional resources to manage with the trauma that they and their families have experienced. In addition to, Susie just made a great point, and that in my experience with public health as a home visitor, that was a dilemma that we had as home visitors going into the homes. We felt like we were opening up Pandora's box. And so how do we actually provide resources for these families that we were serving? Yes, we were working with first-time moms, but in addition to that, we were also working with the family as a unit, as a whole. And so what the approach that the program took was, we wanted to make sure that as nurses that we had, public health nurses, that we had additional resources within the communities that we served, that we had key stakeholders and community collaborations to really work with our families that were in IPV situations. And so realizing that the nurses themselves weren't equipped to handle that because a lot of the follow up and follow through didn't happen. We needed to really be that advocate, be that case manager, be that support person for the mom or dad during the situation. So what happened with Nurse Family Partnership, we actually took it a step further and partnered with, I know they have partnered with DMH and actually hired mental health clinicians to actually be in the home with the families. And that's been a process. No, I'm no longer with Nurse Family Partnership. However, understanding the importance of mental health, whether you're in a home setting or in a clinical setting, and making sure that these families are getting the resources and follow-up is so important. And so I can, say that when we are privileged to have our families come back to see us, that with the continuity of care, asking those questions as to how is therapy going, looking at the behaviors of the child, in addition to the family dynamic, plays a vital role into making sure that that they're getting the services and that it is beneficial to the child as well as to the mother or father and the whole family dynamic involved.
Thank you so much. I also, in my continued commercial for the DV Council throughout the presentation, I put our website in the chat box. We have a number of resources, including a resource booklet available in a number of languages, which can be downloaded, that addresses not only people who are surviving DV, but people who feel that they may become violent and so forth. So that's available on our website. So moving on, you've all mentioned some practical solutions that you've talked about and how to and what's going on in the clinic. But if you could talk a little bit more specifically about what practical solutions exist for talking with patients, children, and adults about domestic violence, and maybe share sort of things that have worked and maybe some things that haven't worked, because sometimes we can learn. I don't like to talk about the things not working, but we can learn a lot from that as well. So what practical solutions exist for talking with patients about domestic violence? So Susie, I'm going to start with you.
Thanks, Eve. So one thing we haven't talked about yet that is really fundamentally important is the concept of universal education. And it was touched upon earlier in the context of prefacing screening questions with patient education. I think that was that something I did earlier today? But universal education is the concept of explaining to patients that what happens in their relationships impacts their health, and normalizing a conversation about the role that violence plays in our lives and in our mental and physical and sexual health. So a practical solution to addressing domestic violence and intimate partner violence in clinical settings is to make it the standard that it's something that's mentioned very quickly with all patients. Futures Without Violence, which runs the National Center for Health and Domestic Violence, has pioneered this model called Q's, which is confidentiality. First, you establish confidentiality with your patient, and there are limits to confidentiality, which we'll also talk about in terms of mandatory reporting. But I won't get to that yet, because our focus here is after establishing confidentiality and making sure your patient is in a private space to even have this conversation, to before you start asking questions about what they personally experienced, you normalize that conversation. It's part of our assessment of a person's health and well-being if they are experiencing any kind of coercion or pressure or even sexual or physical violence. And it does take a little more time than asking a checkbox question, but it's not extremely time consuming. When people do have something that they're willing to discuss with their healthcare provider, that's when things start taking longer, which is why all clinical settings need to be prepared in a practical way. Because when a patient decides to share with their healthcare provider that something is going on in the home that's a threat to their health or perhaps their children's health, the flow of the clinic or the emergency department or the urgent care may slow down, and people need to come to each other's aid in these settings. So there needs to be a conversation with the person's supervisor. I'm going to need to spend, or the clinic manager who's putting patients through the process, letting somebody know I'm going to need another 15 minutes with this patient and we need the referral here. So just having a plan in place that allows the clinical setting to flow properly. And again, the normalizing of this issue. This is such a common problem in our society. I mean, IPV affects a very large proportion of people. The estimates are, there's a range, we could say it's 25% to 40% of female people experience this in their lifetime. But it affects the whole family. So even if the person is not the direct victim of abuse in their home, it's still impacting them. So it is something that should be incorporated in healthcare on a more routine basis in a country where violence is epidemic. And that's why the conversation and not just the screening questions are really important. I'll stop there.
Thank you so much. Dr. Tom, what practical solutions have you found to be successful, or even things you found not to be successful?
Well, I certainly agree with the issue of the time, but one of the things that, again, is an advantage that we have in the medical setting is that we are really used to talking about things that people sometimes shy away from or blush over, things like poop or the, whatever, obesity, things that oftentimes people in normal conversations with each other are reluctant to talk about. When someone's overweight, when they come to a medical visit, we're not bringing it up to shame someone or to judge them. We're bringing it up to discuss their health conditions and how they're related. And I think being in an environment like that, where it is safe to ask, are you safe in your home without judgment, gives us this really great opportunity to develop a trusting relationship. I also think that people, for better or for worse, and in my case for better, tend to trust their healthcare provider with their secrets in a way that is meaningful and that we need to really honor and respect. And so thinking about how to approach those things without judgment, and also while respecting privacy. And the reason I bring this up is because there are limits to that privacy, as you all know, because many of you on this call are mandated reporters. We need to be sure that we ask questions that we know how to respond to and are prepared to respond to. When a 10-year-old tells you that somebody is hurting them, it's not an option to keep that a private conversation. But so to figure out how to work within that trusting relationship, to move on to successful therapeutic interventions is really helpful. I have had many situations where I've been caring for a child whose parent is really in crisis, but who is not ready to seek their own mental health treatment or move to the next level of getting support. And even though I'm not in any way a mental health clinician, I do feel that the therapeutic alliances that I've been able to develop with parents like that helps get them ready to seek the professional support that they can seek when they're ready to move beyond me. And I think we often do that in medicine. And I want to be very clear, I am not a mental health clinician, but I do a lot of emotional and mental health support. And so for me, what that means for me in terms of developing strategies is spending as much time as I can learning from my colleagues who actually are the real deal in the mental health world, so that I can be a nice bridge for my patients, caregivers, and my patients themselves to the appropriate mental health or other services when they're ready.
Thank you so much, and thank you for underscoring the need to break down the silos we have across all of these, both departments and fields. Shanika, do you have other practical solutions that exist that have worked for you in talking to people about domestic violence in your practice?
I want to echo what Susie and Shannon already mentioned. I think the most important tool that has helped me is really developing that therapeutic relationship, trusting relationship with the families, having that container of safety net there. I know what I have done when I have suspected has been to do more frequent call-ins or appointments, reaching out to the patients to make sure that their needs are being met. I find that when I'm open and available to them, more has been disclosed. In addition to that, being open and upfront and honest has always worked for me, and letting them know what my intentions are as a provider and providing care for them and ensuring their safety for them as well as the other individuals in their home is top priority. So another thing that I know within our clinic that we do, we often go through, again, we're in a unique situation where we have cases that come in where domestic violence has already been identified. And so what we have done is integrated our DHS social worker to actually work with our patients that are in the home of the parents. And so on those conversations and those assessments that we, the providers, do, in addition to mental health, DMH being involved, we connect those families that are in the children that are in the home of the parent, and it's documented of domestic violence with our DHS social worker. And so for me, providing a warm handoff, doing more in-depth questions with those families where the children remain in the home, and assessing those families, and then doing a warm handoff with our DHS social worker has been key, because she's able to then provide her own assessment and provide resources to the child as well as the mother. And so that's really helped. So having that collaboration with those, like Shannon mentioned, that have the expertise does truly make a difference.
Thank you so much. Dr. Tyne, the next question is builds off of something you mentioned. You mentioned mandatory reporting, and as far, there's both mandatory reporting with regards to children and also with regards to adult injury from domestic violence. So the question is, how can medical providers position themselves to prevent and intervene, and how is this complicated by issues of mandatory reporting?
Yeah, I think it's always hard. Mandatory reporting is a challenge and also a really wonderful crutch, because sometimes you don't have a choice. And one of the things that I think is really important in all of this is doing the same thing the same way every time. And we all know that we have biases that we either are aware of or unaware of that lead us to make decisions about what's going on in a family and why it's happening and whether it's justified or not. And I think being a mandated reporter helps take away some of those biases. And I'll just tell a quick story because I think it's really telling. When I used to work in San Francisco, and on the ward, there were 2 children admitted for home accidents. One of them had had hot tea spilled on her lap while her father was reading the New York Times. And so she got a burn in her groin. And the other child had a burn on their arm from pulling a hot dog fryer off a counter while running by and hitting the cord. And without telling you any more about that difference in those home accidents, other than the background of the family. And I think what we need to think about is how we approach these things the same way every time, and use the resources we have, because mandated reporting is not a bad thing. But I also think we need to use those resources judiciously, because I actually sometimes am concerned about over-reporting, because there are times when somebody is in a relationship that may be challenging, but when you try to decide what the line is between abuse and not abuse, and so I'm in the abuse world, not the IPV world, and you spend a lot of time figuring out what the gray zone is and trying to decide whether to report or not report, you're missing the point. The point is that person needs help, and how can you best provide it? And sometimes it's best provided through mandated reporting and engaging DCFS and others in the care. And sometimes it's best addressed by building, as Shanika mentioned, a strong therapeutic relationship and discussing the components of someone's life that led them to, for example, use corporal punishment, or led them to be in a relationship that's potentially abusive, but quote, not abusive yet enough for me as the provider to report. So I'm not sure if I'm totally answering your question, but I think for me, the key in that area is again, to be strong and clear and try to take the same approach every time, so that when you manage yourself as a provider, and again, we're speaking medically today, you manage yourself as a provider, you do everything you can to make sure that what you're really doing is supporting that individual and or family in their particular circumstance with the resources you have available. Does that help? I don't know.
Yes,
I
that
don't
does
think that's
help.
your question.
I think everybody wants to go to the three of you for medical care because you're the most compassionate people there are. So thank you. Shanika, how do you feel about that? What can medical providers, how can they position themselves for prevention and intervention? And how does it get complicated by mandatory reporting?
You know, again, I have found that being upfront and honest about, you know, your role and your intention as far as mandatory reporting and what that means, and understanding that my role is to make sure that you and your children in the home are safe. And so it is difficult. It has, I have had experience where in both the home environment and in the clinical setting where patients start to not want to divulge information. So then you have the missed appointments, you have not following through. And so because they're afraid, they don't want to, they don't know where to turn. And so I think with the mandated reporting, what's so vital is that as providers, the clinics, that we are equipped in how to actually have those conversations with the families that we serve, because it's difficult. Those are this topic, you know, can be challenging, especially if you're not comfortable. And someone already mentioned that when we do just the check boxes and no follow through, you don't really have the guidance on how to actually manage or actually work with the patient. So in my opinion, I think that again, I just go from my gut and my heart, and I have had to actually have feel that I am serving them. Does that make sense?
Yes, it does. So, Susie, I'm going to call on you 1 second. Dr. Tyne had something she wanted to add.
No, sorry, that was from before. It's okay.
Sorry about that. I just looked at the thing. So, Dr. Baldwin, do you have speak briefly to the requirement for adult reporting in domestic violence? People may not be familiar with that.
Yeah,
So,
of course.
Go ahead.
Thanks. So yeah, I will echo a lot of what Shanika and Shannon had to say, but just so everyone's clear, California is one of few states that does have a mandatory reporting requirement for domestic violence in adults, and it's limited, but it's in the presence of a physical injury caused by assault, or in the presence of an injury caused by a firearm. We as mandated reporters are required to call these cases in to law enforcement. And there, of course, are reasons why this law was passed, and there are surveys that find that some survivors of violence endorse these policies, but they are also very difficult. And when we think about intimate partner violence, domestic violence, we have, I'll speak on behalf of healthcare providers. There's a lot of bias, and this was, Shannon mentioned this earlier, in the context of after an injury is identified in a child who winds up getting put into the system and who doesn't. But even the way we discuss these issues with our patients often reflects our underlying biases, who we talk to about these things and who we don't, as well as with the way different patients, different people respond to the idea of notifying law enforcement. So we're all very well aware that law enforcement practices in the United States have never been just and have never been equitable. So a person's experience growing up with law enforcement in their community may very much impact the way they feel about their doctor, nurse practitioner, midwife suddenly saying to them, I'm sorry, I'm going to have to call this in because I see you have this terrible bruise on your leg that your partner gave you. And that can shatter a relationship between a healthcare provider and a patient. So again, this mandatory reporting law for adults, it doesn't refer to the presence of mental health problems, for example, that are secondary to intimate partner violence. It doesn't even refer to these chronic conditions that are affected by the experiences of trauma that may make them more prevalent or worsen other health conditions. But the conversation about violence, again, the normalizing and treating all patients the same, I think in adult medicine, it's not always in practice done that way, that we're not expecting to talk with every patient about violence in their home and in their community. But setting that standard up front is really important so that people know what might happen if they tell us something, that there are certain things that we have no choice as healthcare providers but to report to law enforcement. And it's a little bit worse with adult cases because when you're protecting a child and Child Protective Services or DCFS is getting involved, it's obviously to support the family. But when you tell your adult patient who does love the person that's harming them that I now have to call the cops, and the last thing that person ever wanted was for their partner, even their abusive partner, to wind up in the hands of law enforcement, it can be devastating. It can devastate that family, it can devastate that couple, it can devastate the relationship with that patient. And I'm not advocating that there shouldn't be mandatory reporting laws. I just think as a society and as physicians, as nurses, as advanced practice clinicians, and with our community partners in domestic violence service agencies and law enforcement, we have to figure out a way to minimize the harm that mandatory reporting can cause. The whole point is to be helping people. So we have to really examine what these systems do in reality and reassess the laws and the way they're implemented to make sure that we're not inadvertently causing more harm than doing good.
Thank you all so much for the wonderful information and your insight. I'm going to turn it back to Taylor right now for some additional questions.
Thank you so much, Eve, and many thanks to our panelists for your insights today. You know, we at the UCLA Pritzker Center have had the pleasure of doing quite a bit of research in this space around the connection between domestic violence or IPV and the child welfare system. And one of the things that's become really apparent in our discussion today is just how interconnected these issues are, particularly with respect to mandatory reporting, regardless of which patient, the adult parent or the child, is being seen. That mandatory reporting is pretty easily triggered. I am wondering if each of you can speak perhaps about a case without giving identifying information, or a situation where circumstances presented themselves which required that report, and how you handled it, and what you might recommend to other providers that might be in your shoes. Because we see the healthcare setting as being this environment of trust and being really a gatekeeper, if you will, to the system. And yet your hands are somewhat tied with respect to how much prevention you can really engage in. So are there any examples of real life cases that you can give that might help others understand how to better navigate these systems and perhaps engage in some prevention or referral? We'll start with anybody who wants to share.
I'll start off by saying that, so since I've lived in California, I haven't provided medicine in a setting where I'd be seeing a patient with an acute injury from assault or a firearm. So I have not had to personally do that call to law enforcement on behalf of a patient who's experienced an assault that would require me to call law enforcement under the statute. But I've done a lot of conversation with other providers and a lot of education of other providers on these topics to use the process. This is with adults, and I'd say also with adolescents, but you guys as experts can comment on that. When that report is required, to involve the patient in making the report as much as possible. And of course, if they are furious with you, that can be hard to do. Letting them know that this is for their benefit and actually having them be part of what you're saying to the law enforcement agent on the other side is also important. Although it's also essential that your patient knows that they are not required to cooperate. For example, in the instance of sexual assault, we know that a lot of people do not want to report a sexual assault that's happened to them. It's often of a rapist, and people may not want to put themselves through that, given that many crimes in the jurisdiction where they happen. So say you're in one city in LA County and the patient tells you that they were abused in their city, which is 5 miles over, but a different law enforcement jurisdiction. You have to call the law enforcement jurisdiction where they live and tell them, but that law enforcement agent may or may not follow up personally with your patient and try to call them, but that patient is not required to cooperate and talk with them. So that is a way of fulfilling our duty to law, our duty as healthcare providers, while also letting the patient know what power they hold and what rights they hold to cooperate or not with the investigation. And I'm sure if we had a law enforcement person on this call, they would have a very strong opinion to add to this. But looking at this, the standpoint of patient empowerment and patient autonomy, which is fundamental to providing trauma-informed care, I think it's our duty to fill both roles, both our reporting role, letting law enforcement know what happened in this case of an adult injured by a firearm or an assault by anyone, including a domestic partner, and letting the patient know on the other side that this is a crime, but you are not required to cooperate and pursue a charge against the person that you share a home with. It's tricky.
Thank you so much, Susie. Shannon or Shanika, do you have any comments on that?
Well, I can share, again, I'm in a unique situation with the actual clinic, working in the hub, providing care for our foster and DCFS families. Yes, I have had experience of not actual IPV, but having to make mandated reporting for disclosure of a youth for sexual abuse. And originally that was not disclosed in the referral that actually came through. And prime example of taking the time to really develop that rapport and trusting relationship. Initially questions were asked, and a casual conversation, like Shannon mentioned, we have the opportunity to really not make the conversation more difficult than what it has to be. And so in a casual conversation, questions were asked about ever being violated. And at the end of our conversation, almost at the end of the assessment and conversation, as I was speaking to the youth on her own, she disclosed to me that she had been sexually abused. And so with that said, when I have conversations with my youth, I also let them know at the beginning that I'm a mandated reporter and what that means, and give them the framework so that it's not a surprise. I don't think that's fair to have someone disclose to you information and you're trying to develop that rapport with them, and then at the end say, oh, well, this is what I need to do. And so I again am truthful and upfront and honest with with my clients. And so she felt she was comfortable with, and actually this was the first visit that I had with her. She felt comfortable in disclosing to me. And so with that, we were able to, of course, as we mentioned before, mental health is already involved. So I did just go back to what we talked about initially, as far as me having to report what she's disclosed to me. Social worker didn't know. I do know that there was an aunt who was somewhat aware of the situation, which was a little bit baffling to me, because I did ask her, let her know that I needed to bring a caregiver in, and we had a discussion with aunt. And so in the follow-up care, we were able to make sure that one, mental health was provided, of course, reporting to DCFS, making additional, and then in addition to that, calling the social worker who was actually on the case. And so to this day, I'm still I'm working with this youth. And so I say that to say, developing, that rapport made a huge difference in youth was comfortable in disclosing to me. Now, on the other side is for adult population. I have had, when I was a home visitor, a situation where I walked into doing a home visit, and at that visit was an actual domestic violence situation happening, or actually just wrapping up. It had occurred, the perpetrator had left. And so with that, again, consistency, being upfront and honest. Before even starting as a home visitor, letting them know what my role is, and that I'm a mandated reporter. And so this client, I was able to, assist her, advocate with for her, help her in getting the needed resources. And at that time, I think I said this to Taylor yesterday, that this client that where this incident occurred was in the home of her boyfriend. And as a home visitor, a lot of times I know in Nurse Family Partnership, we would often see domestic violence, or IPV, in young women who were actually in the home of their boyfriends versus those that were actually in their own home environment. And there's, more layers to that, of course, but that's just an example of, and I kept the client. She was, very, we continue to work together. And so just really being that resource, being that advocate, being consistent, and showing, giving that care does make a difference. I'm sorry, I went over, I know.
Shannon, do you want to close this out?
Sure. I just want to say one thing that I tell everybody: don't ever call DCFS or law enforcement without telling your client or your patient that you're doing that. 100% of the time, that will undermine your relationship. Just don't do it. It's hard, but it's way hard. It's hard for you because it's awkward, but there is no, if you want to break the therapeutic alliance, trick your patient. Like, just don't. And so what I would say is, just to finish this up in terms of how you report and how you report well, because we will all have to do that. When I used to work in San Francisco, the agency that supported us was called Child Protective Services, CPS, and the agency here is called DCFS, Department of Children and Family Services. They're both the same. They do the same thing. They all have the same goals, but I love the word protect in child protection services, because when you make a report, DCFS is not the bad guy. And frankly, neither is law enforcement. I understand why those people or those entities get labeled that, but if you can remind people that when you make a report, whether it's to Adult Protective Services, law enforcement, or to Child Protective Services, you are doing it with the goal of protecting a patient, their family, a child, whatever. And in those situations where you frame it in a way that you're trying to provide support, I've had great luck with getting people services. I mean, a lot of times the reasons I have to call are because people have the inability to seek appropriate medical attention for their kid. And there's lots of reasons why that happens. And one of them may be IPV and being in a situation where they don't have the freedoms that they need to get their child care. But whatever they are, the services that you're trying to access to support your patients and their families are to help them, not to remove their kid, not to send them to jail. And I understand that sometimes those are the consequences, but you talk to anyone who works for DCFS, they will remind you that the vast majority of children and youth that are involved with DCFS are residing in places where they still have access to their parents, right? And children love, just like women or people who are being victimized by adult partners love the person that's abusing them. Children love their abusers as well, right? People do bad things, but they're not bad people. I mean, that's how I feel. And so thinking about how to frame this in a way that what you're doing when you're supporting getting someone out of a domestic violence situation or a child abuse situation, talking about how to support and protect them from future violence, that's going to be the best approach. We know, and I'm sure this is true with adults, we know that the children who die from child abuse, if you look back at their records, they will have evidence of small things. So let's get these people, whether they're children or adults, when the small thing is going on, when the red flag is there or the small bruise, not when they have the skull fracture or the, the horrible broken bone or something worse. And so I think taking that prevention mentality and really thinking about how we can provide culturally, linguistically, situationally appropriate care to help protect them, I think we can partner much better with the agencies that are working to support us in the medical field.
Thank you so much. Thank you so much. Let's thank our speakers for their insightful contributions today.
Taylor, I just wanted to make sure, because I talked sort of negatively about that reporting, I just want to say that domestic violence is lethal, and that is the goal of making these reports, as Shannon just very eloquently described. So it is the goal. I just hope that our systems can rise to the occasion and link people with services and not just the criminal justice side of things for adults as well.
Thank you so much, Dr. Baldwin. Let's thank our speakers for their contributions and also our medical students for theirs as well. We're very grateful to all of you for joining us today. We want to acknowledge in closing that this is a very complex topic, that folks that are seeing child abuse and neglect happen on the front lines. It's a very difficult situation to navigate and know what to do. And simultaneously, the experiences of domestic violence victims and survivors is incredibly challenging. And it's at that intersection that our work lives and what we're trying to best understand how to proceed and what to do going forward. I want to end with a few closing remarks. We will be hosting a summit on domestic violence and foster care in May. It will be on May 13th. If you'd like to receive notifications about that event, please sign up at the link in the chat. Brittany will put it in there now. We also invite your feedback on today's event, which we will put a survey link to in the chat as well. This series will continue with 3 more sessions. Next week, we are discussing men and fathers. Please sign up on our Eventbrite page. And you can also follow us on our website or on social media. The Pritzker Center website, as well as our social media, will be added to the chat. You can contact us with any questions. And again, we thank you so much for joining us. We will also post the recording within a few days. Thank you so much, and many thanks again to our speakers. Have a great day.